So, Dr. Ken Ameniampon, can you please start us with a prayer?
Shall we pray? Father, we thank you for today's session. We pray that through this session we'll gain more knowledge and understanding to manage our patients and clients better. Pray for your protection and for a smooth presentation. In Jesus' name we pray. Amen.
Amen. Thank you very much. As we are all aware, cardiovascular diseases currently is the leading cause of mortality worldwide, and of course in our beloved country as well. In the sub-Saharan and the low to middle income countries, over 75% of mortalities come from this part of the world. The problem is that, yes, the prevalence may be similar or even higher in the western part of the country, but their mortalities are low. And for us, we think that if the primary care is strengthened such that we can reduce the complications from the major risk factors, then we are going to reduce our mortalities. And of course, the major risk factors that all the work that are being done are found is hypertension, diabetes, our hypercholesterolemia or hyperlipidemia, obesity, and the others. Today, we are talking about one of the major, hypertension. And currently, hypertension has been found to be one of the major, if not the major, cause of cardiovascular diseases in the country. And we want today to equip every primary care physician from the district level to the sub-district level, and of course, even to the CHIPS compound. And of course, the secondary centers as well, our primary care physicians at the teaching hospitals, and of course, all doctors, so that we can be equipped enough in terms of education, in terms of diagnosis, and the management of this condition, so that we can prevent the increasing incidence of cardiovascular diseases. Today with me, I want to say in studio and in our conference room is two great men who are knowledgeable in this space to give us presentations and to equip us with the knowledge that we need. Our first topic is going to be on the epidemiology, prevention, and diagnosis of hypertension. Epidemiology, prevention, and diagnosis of hypertension. And to do this for us is my very good friend, Dr. Saeed Jibril. He is a family physician and he works with the Bank Hospital. He has a lot of interest in patient safety, women's health, and of course, non-communicable diseases. He is a fellow of the West African College of Physicians, and we have him to give us a presentation. Ladies and gentlemen, get glued to your seats and listen to wisdom. Dr. Saeed Jibril, please take the floor.
Good afternoon, Mr. Chairman. Good afternoon, Mr. Chairman. Good afternoon, colleagues, both here and online. I'll be leading the first part of this webinar, and my case is cut out. It's simple. We will talk about what hypertension is. What is the definition of hypertension? If you don't know the definition of something, you probably don't know it. So we will get the definition right, how to diagnose and confirm what hypertension is. Then we will talk about epidemiologic characteristics of hypertension, right? So the outline basically is that the definition, we will grade and stage hypertension. Then the basic principle underlying the pathophysiology of hypertension, we will say something about it. Then prevention. And of course, something on risk profiling. What is hypertension? Arterial hypertension. Okay. Basically, the definition is based on repeated office blood pressures of systolic blood pressure of greater than 140 millimeter mercury and a diastolic blood pressure greater than or equal to 90 millimeter mercury. Now, I must make a point that there is a continuous relationship between increase in blood pressure and an increase in cardiovascular disease, including renal impairment and fatal events. Okay. Basically, this is the reason why we are here. We want to learn what hypertension is and then try to prevent these complications. Okay. Starting from blood pressures of 115 millimeter mercury of systolic and then 75 millimeter mercury of diastolic. Starting from there on upwards, cardiovascular events, the risk of cardiovascular events increases. So getting a threshold for hypertension, say the threshold at 140/90, is just a pragmatic definition, basically, to allow us have a simple to make diagnosis and then point to start intervention. This is the threshold at which intervening in dropping the blood pressures far outweigh inaction or doing nothing. Hypertension has types, basically. There are two of them. We have primary or essential hypertension, and then the secondary hypertension. The primary hypertension, as we know, has the bulk of the cases we see. The majority of the fraction of the individuals with hypertension are due to essential hypertension, and it originates from interactions, complex interaction of genetic factors, environmental factors, and then aging processes as well. And the hallmark of the hemodynamic characteristics is systemic vascular resistance. It's been said that there are more than 1,000 genetic factors that are responsible or predisposes individuals to hypertension. And when all these systems, the complex interaction of environmental, aging process, and play out, it basically will lead to increase in systemic vascular resistance. And that culminates in hypertension. Of course, we cannot forget to mention the renin-angiotensin-aldosterone system, and of course, central and peripheral autonomic cardiac dysregulation, if I'm allowed to say that. And yeah, so all this play out to produce the elevated blood pressures. Yeah. Do we have to classify hypertension? Yes, we need to. We need to classify hypertension into grades. That will help in fashioning out how hypertension is managed. So this is by the European Society of Hypertension, and this is the 2023 guidelines, where hypertension is categorized, blood pressures are categorized into optimal, normal, high normal. Then you have grade 1 hypertension, grade 2 hypertension, grade 3. Then we have isolated systolic hypertension and isolated diastolic hypertension based on the blood pressure values. Okay. So blood pressures of less than 120/80, it's optimal. This is the blood pressures we should all vie to have. And normal between 120 to 129 systolic, and then 80 to 84 of diastolic will be classified as normal blood pressures. Then you have category of individuals who we usually would say they are elevated blood pressures. That's the high normal. You are not saying they have hypertension, but they are kind of a borderline, and they still could have long-term risk of cardiovascular events. That would be systolic blood pressure of 130 to 139, and then a diastolic pressure of 85 to 89. Then the real people or individual with hypertension is the grade 1, which is 140 to 159 of systolic, and then 90 to 99 of diastolic blood pressure. From 160 up to 179 classified as grade 2, and then grade 3 is greater than 180, greater than 110 of diastolic. Then you have the isolated systolic hypertension, where the diastolic blood pressure is normal. It's less than 90, but you have a systolic blood pressure greater than 140. Then diastolic, where the systolic blood pressure is normal. These are office blood pressures, actually. Office blood pressure less than 140 of systolic, and then greater than 190 diastolic will be classified as isolated diastolic hypertension. Yes. Yes, we can also have other values that differ from office blood pressures or office values through the use of ambulatory blood pressures or just a home check. You know, these blood pressures are, they mimic much of the individual through environmental condition, their daily activities, and then when they are asleep as well. So office blood pressures of 140 over 90, greater than that. And then ambulatory daytime blood pressures or awake time of greater than systolic BP of 135, and or a diastolic blood pressure greater than 85 is also classified as hypertension. You realize that these values are lower, but at the end, their risk of cardiovascular event actually corresponds to the office blood pressures of 140/90. Then the mean 24-hour blood pressure, if you are on the ABPM, the ambulatory blood pressure monitor, you should be looking at greater than or equal to 130 over 80. That will classify it as hypertension. And if you are just using the device, the automatic device at home, checking your blood pressures intermittently, the threshold will be 135 over 85. So let's take note of that. Yes. Aside grading hypertension, you can also stage it. Okay, this will guide the management, and then when to refer, actually. It also will help you to risk profile your hypertensive patients. So stage 1 hypertension will be an uncomplicated hypertension, regardless of the number, the value. But patient has no hypertension-mediated organ damage. There's also no established CVD. This patient may have a CKD, that's chronic kidney disease stage 1 or stage 2. That will be classified as stage 1 hypertension. Stage 2 hypertension, regardless of the blood pressure values, if the patient has hypertension-mediated organ damage, or is diabetic, or has a CKD stage 3, that patient will be at stage 2. Then stage 3 is when there's established cardiovascular disease, or CKD stage 4 and stage 5. So let's now risk profile our patients. Okay. When you combine the grades and stages, you can risk profile your patients into low risk, moderate to high risk, and then very high risk. Remember, we're just controlling the blood pressures because of the cardiovascular risk or cardiovascular events that they are prone to. So you must as well just know their risk profile before you start treating them. Yes. So you have the stage on the left side and then the grades on the upper side, and you kind of cross-match them. So if a patient has stage 1, so the green areas are the low risk, and then the amber to the gold are kind of high risk and moderate risk. And then the very red areas are very high risk. So you may want to refer this kind of patients to, a unit that is specialized in managing hypertension. I would advise that. Okay, when we classified hypertension, we said that hypertension was in 2 types, secondary and primary, okay? Primary, there's no specific cause. Of course, we know there are risk factors. For the secondary hypertension, there are identified specific causes, such that treating the cause would have treated or cured the hypertension, actually. I think you can talk of cure at this point, right? Yes. So the cause could be from a renal parenchymal disease, which you will elicit through personal history and then family history of chronic kidney disease. Urinalysis may give you a hint of proteinuria, hematuria, and then a renal ultrasound could also help you. Primary aldosteronism is also a known secondary cause. In fact, this is about the commonest cause in certain ages from below 40 years. Primary aldosteronism is considered the commonest cause. Yes. So the history is there. They will have symptoms of muscle weakness from hypokalemia or muscle cramps and tetany. Your labs could show hypokalemia or an elevated plasma aldosterone-renin activity ratio. And then you can have a confirmatory test by doing the saline suppression test. And of course, adrenal CT will also help you. Renal arterial stenosis could also be a secondary cause. Then you have pheochromocytoma. Let me rush through this slide. Pheochromocytoma and then Cushing's disease are all secondary causes. You also have thyroid disease as well. And yes, thyroid disease, either hypothyroidism or hyperthyroidism are all secondary, secondary causes of hypertension. Now, hypertension too has phenotypes, especially if you have the luxury of having an ambulatory blood pressure measurement or a home blood pressure check. You could identify some phenotypes, okay? One could be the white coat hypertension. White coat hypertension denotes that these individuals have a higher office blood pressure and then a lower or normal home blood pressures. Then you have the masked hypertension, where the individuals generally have a normal office blood pressure. It's tricky here. Their office blood pressures are normal, but they are out of office, so home blood pressures will usually be high. It's kind of tricky. How do you go about identifying this? Majority of these patients will come from people who have some kind of elevated blood pressures, but not hypertensive. So that may push you to do an ambulatory blood pressure check, and you could just identify them. Then, of course, we've mentioned isolated systolic hypertension, isolated diastolic hypertension. Then There's also nocturnal hypertension, which of course the ambulatory blood pressure monitoring is the only way out to get this diagnosed. The non-deepest and the deepest. In fact, nocturnal hypertension is said to carry a higher cardiovascular risk compared to, a high mean daytime blood pressure. Then you have a orthostatic or orthostatic hypertension or orthostatic hypotension. Of course, we know there's orthostatic hypotension. So this is the reverse. The reverse gives you orthostatic hypertension. And then erect or standing position, there is an exaggerated increase in the blood pressure. And that could give you orthostatic hypertension. Because of the prevalence of hypertension, and then its role in the causes of death and morbidity, you must screen for it. It's a huge public health concern, and it's one of the reasons why we're talking about it today. Unfortunately, considerable proportion of individuals with hypertension in the population are not aware if they have hypertension. Approximately, some literatures put it at 10%, depending on the population. So we will encourage opportunistic blood pressure measurements. Elsewhere, at the barber shops and pharmacy shops, it's been realized that when you check people's blood pressures at these shops, it can help you to diagnose some people. And in fact, even people who are on medications, this kind of opportunistic checks or measurement helps to have their blood pressures controlled. Okay. The United States Preventive Service Task Force recommends that individuals from 80 years and older have their blood pressures checked, or they should be screened for blood pressures, for hypertension rather. And yearly screening is recommended for adults 40 years and older, and obese individuals, or even abnormal body weights. Yes. And of course, the Black population and individuals with high normal blood pressures too are just time bombs. They could also, in just the near future, have hypertension. So they too, we should keep our eyes on them. Then of course, postmenopausal women are at a higher risk of hypertension compared to their fellow men at similar ages. So we should screen postmenopausal women too yearly. Then women who have had history of gestational hypertension, or if they've had eclampsia during one of their pregnancies, their risk is higher, and we should pay much attention in checking their blood pressures as well. Yes, and of course, blood pressure checks should be routine for any hospital visit for individuals 18 years or older. How do you confirm blood hypertension? How do you confirm the diagnosis? Because the point we must note is that office blood pressure has a very high variability, including the fact that there is the white coat effect hovering around us. So we should be careful in rushing to diagnose individuals and tag them with hypertension because of the variable nature of the blood pressures. So it is advised that for people with blood pressures of greater than 140/90, office blood pressures, we should check the BP 2 to 3 times within 4 weeks and get your average. Then you can confirm the hypertension if you are using just office blood pressures. Of course, except the individual present with grade 3 hypertension of greater than 180, for them, you can actually start your treatment whilst working them out. Yes. Because they carry a higher cardiovascular risk. Yes. Or if the person has an elevated blood pressure of, say, 140, greater than 140/90 around stage 1, and there is the presence of hypertension-mediated organ damage, you can treat those. You may not need to recheck and recheck. Once you identify that there is the presence of hypertension-mediated organ damage, you should consider them as hypertensives and get them treated. Of course, if ABPM is available, we will recommend that you use that for those individuals who just had stage 1, stage 2 in their first or second visits. Or you can let them do the home blood pressure monitoring and bring it back in 4 weeks so that you can confirm the diagnosis. This will also help you to know that, identify the phenotype of the kind of hypertension the individual may have. In the hospitals, how should we check our blood pressures? Okay. I haven't seen the mercury sphic use. It's been banned. I don't know any hospital that will currently use the sphic, a mercury sphic. So we will encourage that you use mercury-free devices. Okay. And of course, these devices should have some features. You don't just pick any machine, automated machine, and start using it. It could mislead you, kind of make you misdiagnose individuals. So the device should be calibrated and validated. And the device should also have a program set that it can take multiple blood pressures, minimum of 3 blood pressures, so that it can take the average for you. And it should have a memory too. It should have some capacity so that it can allow you to recall previous blood pressures as well. And of course, for individuals with atrial fibrillation, it will be preferred you use the auscultatory measurements to be able to get the blood pressure right. Of course, some automated devices have an atrial fibrillation algorithm inbuilt, so the machine can identify that this individual has an AFib, and then it will calibrate the blood pressure rightly for you. Okay, so this slide just gives us a picture, and it characterizes both the conditions and the posture and the number of measurements you should undertake when you want to take someone's blood pressure. So number 1, use a validated automatic electronic device. We advisable to use the upper arm cuff device instead of the wrist, if you have the resources. In a quiet room, not a noisy room. The person shouldn't have smoked or took coffee or any kind of food just before that. And they shouldn't have exercised in the last 30 minutes before the measurement. All this could mark the value you will be taking. And they should remain seated and relaxed between 3 to 5 minutes. And there should be no talking within the time or in between the measurement. And they should sit with their back relaxed. And the picture says it's all. So at the office, you take 3 readings, right? 1 minute interval. And you use the average of the last 2 pressures. Some will say the average of the lowest 2. Okay. Depending on the method you use, you will get a value that is near true value of this individual. You realize that we rush some of our patients to check their blood pressures, and we kind of increasing the white coat values we have in our facilities. Okay, some few epidemiologic features of hypertension. Hypertension is the most prevalent cardiovascular disease in the world. It's up to 1.28 billion adults between the ages of 30 to 79 are identified to have hypertension. And mind you, it is said that up to 10% of any population may be undiagnosed. So if you add that to this figure, then you realize the enormity. When it comes to sex, which is a biological construct, and then gender, a social construct, blood pressure play differently. For instance, in men, before menopause, compare men and women, before menopause, at the same age range, men generally will have more high blood pressures compared to their female gender. But after menopause, the female gender catches up, and their population of hypertension among that group may exceed their male counterparts. Okay. Of course, we know that age is a risk factor, so the prevalence of hypertension would increase with age in both sexes. It's a non-modifiable risk factor. You celebrate one birthday, and another also just means that you are increasing, your risk of having hypertension increases. Sometimes patients may put it to that dog. I've been fine. For the past years, I've been fine. And today I went to the hospital and I was told I have hypertension. I don't believe it and all that. Yeah, last 2 years, you weren't plus your age now. So your risk has increased. Okay. And like I said, effect of menopause increases the chances of having elevated blood pressures because of the estrogen and androgen imbalances will increase the risk. Again, women with premature ovarian failure, polycystic ovarian disorder, or infertility all have increased risk of hypertension. So we should pay attention to this group of women in identifying hypertension amongst them. So blood pressure and cardiovascular risk. Elevated blood pressure is directly proportional to an individual cardiovascular risk. Okay, and cardiovascular risk associated with a 24-hour blood pressure and nighttime BP is said to be steeper in women than in men. So if you were to decrease, or if you were to control the blood pressure in a woman, okay, you potentially will decrease the risk far, far higher compared to their male counterparts. Okay, and of course, decreasing the blood pressure will also mean that you are decreasing the risk of myocardial infarction, heart failure, stroke, and all the associated morbidities that come with elevated blood pressures. Okay, I've mentioned some of the phenotypes already, so we'll move on. All right, let's look at prevention. Prevention. When it comes to prevention of hypertension, we basically can prevent the essential hypertension, right? Yes, because we know the origin of it are risk factors of genes, genetic basis, environmental factors, and then aging process. The aging and the genetic factors are non-modifiable ones. We cannot do anything about them. But the environmental factors, which can include any of this we'll be mentioning, we can modify them. lifestyle is the fundamental component of trying to either delay or prevent hypertension. It is said that people with lifestyle that is related to healthy lifestyles have a decrease of 4 to 5 millimeter mercury of blood pressure compared to their counterparts who do not have a healthy related lifestyle. And one significant variable in lifestyle that you can use to reduce your chances of hypertension or delay is weight reduction. Obesity or high body weight is associated with increase in blood pressure and then increase in cardiovascular risk as well. For every 1 kilogram of body weight you add on, your blood pressure increases by 1 millimeter mercury. Okay, and we should try and avoid what is described as weight cycling. Weight cycling is people who are obese or overweight. They make attempt to reduce their weight. They reduce the weight, they lose the weight, gain it back, reduce it, gain it back, that kind of cycle. It puts you at a more higher cardiovascular risk. Okay, then diet. The DASH diet, it's been well acclaimed as the kind of diet that we can use to reduce our chances of hypertension. Yeah, so basically this diet contains grains, fiber, vegetables, and then low-fat diet with vegetables and fruits tend to have high calcium, magnesium, and potassium. So people with this diet tend to have, people who are on this diet tend to have a lower cardiovascular or blood pressure elevation. Then smoking. It is said that cessation of smoking is the most important preventable cause of death and reduction in cardiovascular disease. And of course, passive smoking or secondary smoking puts you at a similar risk of hypertension. So we should try and inquire from our patients their status, whether they are smokers. If they are not, whether they are secondary smokers, and try to counsel them to quit smoking. Then stress and anxiety are risk factors as well, especially psychological stress tend to increase individuals' blood pressure. So meditation, breathing exercises, yoga, mind-body interventions tend to reduce stress, of course, and anxiety. And that in turn will lower either your blood pressures or reduce the risk of a cardiovascular event. Then noise, exposure to noise and air pollution is also a significant risk factor for hypertension. It may be one of the reasons why you may have high number of people with high blood pressures in urban areas compared to the rural folks, because of the noise and the air pollution in the urban areas. Yes, and then moderation to alcohol. It's also a huge factor. 1 to 3 drinks per day increases risk of hypertension in both sexes. Because the controversial low amount of alcohol as to whether it has health benefits or not still remains controversial, right? Some will tell you that alcohol has no single benefit, but the jury is out there. But of course, so for our patients with hypertension, when we're trying to manage it, we shouldn't just be interested in adding medications and increasing their doses and all that, we should look at all these factors and try to help out. Of course, increased level of daily physical activities and regular exercises are all factors that we can use to lower our blood pressures. So epidemiological data shows that habitual levels of exercises and hypertension are inversely related. So the higher the levels of your physical activity or exercise, the lower your chances of or your risk of having hypertension. To the extent that just 150 minutes of exercise in a week actually reduces your risk of hypertension by 6%. That's significant if you ask me. Okay, then restriction of sodium intake. Some of us like our salt, including table salt, adding it even at the dining and all that. So we should try and reduce that. It is said that the reduction of salt intake up to 3.6, between 3.6 to 2.7 can reduce your risk of cardiovascular risk by up to 26%. Then augmentation with dietary potassium significantly can reduce your blood pressures. Yes, there is an association between dietary potassium and hypertension. It's a U-shaped relationship. So if your potassium intake is low, it could have an impact in elevating your blood pressures. And if it's also too high, a similar thing. So it's in moderation. So I will advise between 4 to 5 servings of fruit daily. Fruit and vegetables will give you enough quantities of potassium to reduce your risk. Some do supplement. 60 millimole, that's like 1,380 milligrams, could also lower your risk of hypertension. Or if you are on treatment, it could reduce the number of tablets that you need to be on. All right. So I will bring my presentation to an end. I was on time, right? And then, so if you have comments or questions, please, you can send them to us, and they will be addressed later on. Thank you very much. Thank you.
So thank you very much, Dr. Said Jibril, on this elaborate presentation. So a few things that let's take home. How do you screen your patients? It's one of the major aspects. We have a number of prescribers that when clients come to the clinic with other conditions, we never even look at their vitals, especially their BPs. Opportunistic. When they come, anybody who comes, just take a look at their blood pressures that were measured. The other thing is that he talked about how we measure these blood pressures. I mean, there are times that you go to the OPD where the vitals are being checked, and when you look at where the cuffs have been placed, or when you look at the size of the arm and the cuffs that are there, you know that the values that you are getting are wrong. Are your nurses checking their blood pressures very well? Are they giving you the right values? In terms of diagnosis, he took us through the various values. Do you know the values for office? Diagnosis, the values for home, measurement diagnosis, ambulatory, BP checks, the values. Let's get note of all this one so that we can pick our clients well. He talked about the prevention. Prevention. I'm always of the view that in our beloved country, it's better to prevent than to get the disease. Because even the economic aspects of it, the cost of medications, the cost of investigations, sometimes can be burden for our clients. So the earlier and the how well we worked on to prevent these conditions, I think the better it will be for our country. And he's talking about all this because he said that it is the #1 cause of cardiovascular diseases in the country. It is causing a lot of kidney diseases. And of course, the mortalities are rising. It is your primary duty, it is my primary duty, that we take a look at these things and make sure that we are serving our clients better. Thank you very much, Dr. Said Jibril. My name is Dr. George Bediakun Ketia. I'm the president of the Society of Pharmacians of Ghana. Sorry, earlier on, I didn't introduce myself well. But next to do the presentation for us is another good friend of mine. These days, if you want to see him, very difficult because he's always working and working and working and working. He works at the Kolebu Cardiothoracic Center. He's a fellow of the West African College of Science. Actually, he's a cardiologist. He also has the postgraduate diploma in preventive cardiovascular medicine. And as I said, these days, all of us and everybody is moving to prevention, because if we do well to prevent these things, we definitely are going to reduce the morbidity and the mortality that we have around. He is in the person of Dr. Eugene Ampofo, who is going to take the presentation on the current guidelines in the management of hypertension, specifically preventing cardiovascular diseases and chronic kidney diseases. Dr. Eugene Ampofo, kindly take floor. Thank you.
Thank you very much, Dr. Nketia, for a kind introduction. And a special thanks also to your association for giving me the privilege to talk on this most important topic. Also want to say thank you to Dr. Seth Nani. He's my senior. He was actually supposed to do this presentation, but for some emergency that came in, he asked me to step in for him, and I'm grateful for him giving me this opportunity. This topic comes in at the right time, especially in the month of May, when May is the May measurement month, where there's emphasis on hypertension and measuring blood pressure and advocacy on hypertension. And my senior, Dr. Jibril, has in fact done the work already. I was wondering what I was going to say next, because he's literally exhausted the critical parts of hypertension, which is early diagnosis and also prevention. As Dr. Nketia mentioned, prevention is most important in our setting because of the peculiar challenges we have with access and cost of medications and the complications that come with hypertension that our system seems not to be ready for in terms of management. So the outline of my presentation would be a brief introduction. Why should hypertension be managed? We'll have a case discussion. We'll look at the goals of evaluation and management, approach to evaluation and management of a patient with hypertension. We'll review the 2024 ESC guidelines with emphasis on the management of hypertension. The reason why we are looking at the 2024 is my topic is on the current management. And Africa, Sub-Saharan Africa, tends to align more with the European Society of Cardiology when it comes to management of hypertension. And of the most recent update is the 2024. And so our emphasis will be on the 2024, and we'll look at some new emerging therapies in the management of hypertension. It's almost 4, and it gets a bit boring just talking to a screen. So I will hope and plead with the participants to interact whilst we do this presentation. So as an introduction, we all know cardiovascular disease is the leading cause of mortality globally, with 20.5 million deaths annually. And hypertension is the single most independent risk factor contributing to cardiovascular disease globally, and Ghana is no exception. Dr. Doku and his colleagues looked at the cardiovascular disease in the country, and of the cardiovascular disease, the single most independent risk factor in Ghana was hypertension, which had a pooled odds ratio of 3.41. The second was diabetes mellitus. So hypertension is very important to look at. And if we are able to get hypertension under control, we will significantly reduce the burden from our non-communicable diseases, because hypertension is the leading risk factor for cardiovascular disease, which contributes a chunk of the non-communicable diseases globally, and also in developing countries where non-communicable disease, cardiovascular disease is occurring about 75% in developing countries. So hypertension is very important to look at. Now, why should we look at hypertension? Now, if we don't look at hypertension, these are the things that will happen. If you look at the eyes, hypertensive retinopathy. If you look at the brain, you're looking at strokes, cognitive impairment, dementia, hemorrhage. If you look at the heart, left ventricular hypertrophy, you're looking at atrial fibrillation, coronary artery disease, myocardial infarction, heart failure. If you look at the kidney, you're looking at glomerular arterial hypertension, which is going to lead to glomerulosclerosis, CKD, kidney damage, albuminuria, proteinuria, which in itself, albuminuria and proteinuria are independent risk factors for cardiovascular disease and mortality. Microcirculation, of course, and endothelial dysfunction, which is the main precursor for inflammation, which forms the foundation for atherosclerosis, which underpins most of the atherosclerotic cardiovascular disease that happens to patients. So this tells you that hypertension is very important to manage. Now, if you look at data, why should hypertension be managed? If you look at major cardiovascular events, this is a forest plot looking at meta-analysis that has looked at management of hypertension, whether in terms of prevention, what does it do? So if you look at the forest plots here, you will notice that when it comes to major cardiovascular events, it's on the left side of the screen. It favors the intervention in terms of reducing blood pressure. And for every 10 millimeter reduction in blood pressure, you see the relative risk reduction of 0.8, which gives you a 20% reduction in major cardiovascular events. If you're looking at coronary artery disease, also 0.83, looking at 17%, stroke 0.73, heart failure 0.72, all-cause mortality 0.87. Yes, renal failure was 0.95, but if you look at the confidence interval, it included 1. And so statistically, that was not significant. But generally, its impact on all-cause mortality is significant, with about 13% reduction. So it tells you that reduction in blood pressure is very important, and therefore we should make a conscious effort. As my predecessor stated, very few people are actually at targets when it comes to the management of hypertension. Now, with respect to kidney disease, if you look at data, an intensive VP control defined as a target of less than 130/80 reduced kidney failure risk by 17% and end-stage kidney disease by 18%. And the benefit is most significant in patients who have proteinuria compared to those who does not have proteinuria. And this has been supported by several data that clearly state how you manage this patient. So the moderator will give you the opportunity. You can unmute and you raise your hands and you'll be unmuted and you'll be given the opportunity to respond to this. Remember, it's a learning thing. We are all learning, we are all interacting, and that is the essence of today's presentation. We learn each day. I'm also going to learn today from all of you. So we have a 30-year-old male, has a BMI of 35 kilogram per meter square, sedentary lifestyle, takes 20 units of alcohol a week, 20 packs, years smoking history, and reports for evaluation and management on account of elevated blood pressure of 150/100 millimeters of mercury, which was measured at a community pharmacy. How will you approach the management of these patients? So basically, that is the case that we are going to build on to do this presentation. So you can electronically lift your hands, you'll be unmuted, and you make your case.
Okay, so from the case, is that a 30-year-old male with BMI of 35 kilogram and a sedentary lifestyle, 20 units of alcohol a week. Now, all these ones we are seeing are risk factors. We need to remind ourselves. We said modifiable and non-modifiable risk factors. Probably is of an African descent. So that is one of the non-modifiable risk factors we can identify here. Then the BMI is a modifiable one. The sedentary lifestyle too is a modifiable lifestyle. And then the 20 units of alcohol is also modifiable. So here in this case, the patient's BP was checked at the pharmacy. So if this patient is presenting to the facility, I'll let the nurses or probably have the BPs checked again. And if possible, I won't start medications outright. We start with the counseling, and then I will ask the patient to do a BP profile for review. Possible.
Thank you very much, but I didn't get your name. If you could. Thank you very much, Dr. Tate. So if I understood you correctly, apart from the identification of the risk factors to help you with risk stratification, you want to establish the diagnosis of hypertension before you proceed. Thank you. Any other contribution?
Okay, so I agree with Dr. Tete. He has a lot of risk factors, most of which are modifiable. And this BP was not in the hospital, so I would want to establish that he's actually hypertensive, confirm the diagnosis, and then in approach to management, start off with non-pharmacological, the lifestyle, which he has a lot of modifications to do in relation to his BMI, his alcohol, about 20 units a week, which we now know no amount of alcohol is safe. Smoking as well, yeah. So mostly non-pharmacological until we establish the diagnosis, then we can go pharmacological.
Thank you very much. So, okay, we have another
I just
question.
wanted to add for the age, 30 years, so I'd look at it a bit more closely and also ask for a family history of hypertension.
Still on the age, is it just the family issue of hypertension? Why does the age strike you? What is your concern about the age?
About the age. So for a young patient who is already started with this, we would want to do better for the patient because if you are going to be hypertensive for many years, it is going to probably worsen the patient's quality of life. There's a chance that if the patient is going to be hypertensive, if are diagnosed at 30 years, and we are going to manage you for maybe 10, 20 years, you are going to be hypertensive for long. So you're at risk of getting more of the end organ damage if you are not managed properly. What I wanted to say was about after making the diagnosis, if I get the opportunity to have a patient like this, I would like to examine the patient properly for possible end organ damage as we had earlier identified. Check the eyes to see if there are symptoms of retinopathy, and then I'll take the time to do early investigations. It is possible that the patient can have an elevated BP of 150, and there's already signs of end organ damage. So I'll take the opportunity to be able to do a renal function test, check for the lipids, do a urine albumin creatinine ratio and all that, because the patient has presented whilst we do the monitoring.
Thank you very much. So,
in addition, concerning the age, he's quite young, so I think we would want to rule out secondary hypertension as well.
thank you very much. So online we have similar comments. So let me read. So secondary hypertension clearly stands out in most of the comments that have been stated. Now kindly Alote says first he will recheck the blood pressure like we stated here 3 times again. And if the blood pressure is still elevated, I will take a history again and basically trying to establish the diagnosis as we've stated. Thank you very much. So clearly, I believe we have the concept, and I agree with you perfectly, because you need to manage someone with hypertension, you need to establish the diagnosis. And managing someone with hypertension is not just managing the value of the hypertension, but managing the person as a whole in total. Because remember that the patient does not come to you with only the hypertension, but comes with other comorbidities. And so we need to appreciate that the goal of management for such a patient is to, 1, reduce cardiovascular disease in these patients, to improve quality of life, and to prevent premature death. So when you're managing a patient, we need to have the goals of managing. What is the goal of managing this patient? Are we just focused on that value, that blood pressure value? Or we are looking at the patient as a whole? Remember, as the earlier presenter said, evidence of organ damage has been associated with blood pressure systolics of 115. So there's really no safe technically blood pressure, but it's based on consensus. And that is why the 2024 ESC guidelines, there is nothing like normal blood pressure anymore. The term is non-elevated blood pressure, elevated blood pressure, and what? Hypertension. The idea is that the concept of normal blood pressure makes it appear that a blood pressure can be acceptable, but complications or target organ damage has been noticed even from systolics of 150. And that is why we should look at the change in the nomenclature. So for these patients, as rightly said, there are obvious problems. He's obese, sedentary lifestyle, takes alcohol, smokes cigarettes, and has elevated blood pressure. Elevated blood pressure because we have not established a diagnosis of what? Hypertension. And as presented earlier by the presenter, Dr. Jibril, you need to establish a diagnosis of hypertension, either by repeat office measurements or preferably the 2024 ESC guidelines is recommended. In fact, that is what we want to do, is an ambulatory blood pressure monitoring or a home BP blood pressure monitoring. But we understand the challenges in a setting where it will not be available in most settings. And so most people will do confirmation by repeat office measurements. But as much as possible, we want to confirm a diagnosis with the ambulatory blood pressure monitoring or home BP monitoring. I will not want to draw too much on that because Dr. Jibril has already given the cutoffs for diagnosis using the ambulatory BP and also using the home BP. But the learning point is you need to establish the diagnosis. Now, what are the anticipated problems for these patients? When you see a patient you are evaluating for hypertension, remember, they come with comorbidity, and your goal is to minimize cardiovascular disease and chronic kidney disease. And they don't come in isolation just with hypertension. So you see the obvious problems this patient has. But what other problems can this patient have? You need to anticipate that. And that is why those are the things you can elicit from your history and physical examination. So from this scenario, what anticipated problems can we have? This patient is obese. So this patient will have what? Obstructive sleep apnea, all right? And if you don't look out for it and improve or manage that, you will struggle with your blood pressure control. This patient may have nocturnal hypertension because what? He's obese. Remember, as Dr. Jibril said, nocturnal hypertension has been associated in literature with worse outcomes. So you want to think of that. This patient may have dyslipidemia. Why? He's obese. Okay, and that may worsen your cardiovascular disease risk. And as we mentioned, the age, 30 years. So this patient may have what? Secondary hypertension. And therefore, your history and evaluation will want to look out for things that may point towards the possibility of secondary hypertension. And as my colleague mentioned, my colleague in blue, I met him in Tamale some time ago, forgotten his name. You want to look for hypertension-mediated organ damage, because remember, we'll get to know that initiation of treatment is not dependent on the value of the blood pressure, but also dependent on the presence of already existing hypertension-mediated organ damage, as you rightly said. And you also want to anticipate that this patient may have diabetes or pre-diabetes because he's obese, takes significant amount of alcohol, is sedentary. So you need to anticipate and evaluate this patient's cardiovascular disease risk in totality. So how do we approach the evaluation and management of a patient with hypertension? One, it's multidisciplinary. We should always remember that in practice, you may be seeing the person as the first point of call, but always remember it's teamwork. All right? You may be a cardiologist, you may involve the family physician, you may involve the endocrinologist. Because if you're dealing with a secondary hypertension that involves, for example, primary aldosteronism or something, you will have to involve the endocrinologist. Cushing's syndrome, you have to involve the endocrinologist. Respiratory physician, if the patient turns out to have obstructive sleep apnea, you will have to work with a respiratory physician. Okay, you have to work with a nurse. You have to work with a physiotherapist. You come to know the benefits of exercise, which has already been stated by Dr. Jibril. You want to work with a nutritionist, a dietitian, a clinical psychologist, because the patient will have to acknowledge and accept the diagnosis to help the patient's care management, which is now recommended. So if the patient has not accepted the diagnosis, if you finalize it, it will lead to what? Non-adherence, and achieving target blood pressure will be problematic. So we need to look at that. You need a detailed history and physical examination. We can't overemphasize this, especially in a resource-challenged environment like Ghana, where you may not get the opportunity to do everything when it comes to evaluation of, let's say, hypertension-mediated organ damage or secondary hypertension. The clues you pick from the history in the physical examination will focus your investigation and help improve your cost-benefit analysis so that you give the patient the best with a little cost incurred. Now, cardiovascular risk assessment, as we said, and evaluation of comorbidities. In this scenario, we are concerned about what? Obstructive sleep apnea, obesity, the alcohol, and etc. that we mentioned. And the question is, has the hypertension been confirmed? Can you do an ambulatory BP monitoring? Can you do a home BP monitoring? Or you have access only to repeat office BP monitoring? Now, which routine investigations can you do? You need to do some routine investigations, and we want to know the recommendations supporting this. So fasting blood sugar, an HbA1c, a renal function test, urinary ACR, fasting lipid, TSA, 12-lead ECG. These are routine investigations. And the next thing is, do you think you're dealing with what? A primary or secondary hypertension? All right. If you think it's primary, fair. If you think it's secondary, you investigate further. Do you think this patient has hypertensive emergency? Because if it's an hypertensive emergency, your approach will be different. It means the patient will require what? Admission and will require intravenous antihypertensives, depending on the target organ involved in the emergency. Further investigations if secondary hypertension is suspected. So you may want to do an echo to look at the possibility that this patient may have a coarctation of the aorta. So let's say you evaluate this patient and you have a radiofemoral delay. So we are thinking this patient may have what? A coarctation as a secondary cause of the hypertension. So an echocardiogram will be indicated as part of secondary hypertension evaluation. You may suspect that this patient may have what? Renal artery stenosis. So you want to do renal artery Doppler. You may want to do an omnipelvic ultrasound because you think this patient may have what? Kidney disease. All right, current function test, and aldosterone-renin ratio. So all this will be informed by a detailed history and physical examination, because you can't go all out doing all this, especially in a resource challenge setting. And further investigations to look for hypertension-mediated target organ damage, as we mentioned. So these are the recommendations for the routine labs for every patient who has hypertension from the ESC 2024. Every patient you are managing for hypertension should have what? A fasting blood sugar and an HbA1c if feasible, especially if the fasting blood sugar is elevated. You need your lipids. You need your electrolytes, your renal function, and TSH. So these are basic 12-week ECG. These are recommendations. So every patient with hypertension needs these investigations. Okay. Now, what are the optional investigations? An echocardiogram. All right. So you think this ECG is abnormal. ECG shows left ventricular hypertrophy. ECG shows pathological Q waves in two contiguously. So you think this patient probably might have suffered a previous myocardial infarction. All right. or your evaluation in terms of history and examination suggests this patient may have heart failure. Remember, hypertension is the single most independent risk factor for heart failure with preserved ejection fraction. All right, so if you think this patient has heart failure, you want to do an echocardiogram to establish whether there's any structural predisposition to this heart failure, and also to assess the ejection fraction, because the ejection fraction will define the course of management of this patient. Either you're dealing with a heart failure, preserved ejection fraction, mildly reduced ejection fraction, or reduced ejection fraction. And that will inform your management. You may want to do a coronary artery calcium score as part of risk stratification. I do think this patient may have increased risks of what? Coronary artery disease. You may want to do a femoral artery ultrasound. So all this should be informed by your evaluation. And it's your evaluation that will direct whether you do this. A fundoscopy may be needed. If patients you evaluate from history and you think this is a patient that probably already has what? Hypertensive retinopathy, you want to do a fundoscopy. If a patient, however, is presenting with hypertensive emergency, blood pressure greater than or equal to 180/110, fundoscopy is not optional, it's compulsory. Okay, so these are the things. Now we're going to go into the recommendations because the presentation is on the current management. So it should not be management based on what I say, but based on what evidence is saying and asking us to do. So with respect to the ESC, European Society of Cardiology, they have their definition in terms of when it comes to the recommendations, the class of recommendation. So when we say it's class 1, it means that it is recommended. Okay, there's no debate about it with respect to the evidence. If we say it's class 2, then depending where the information is, we have 2A, 2B. 2A, you should be considered. 2B may be considered. If it's 3, it means it's not recommended. All right. Then the level of evidence informing these classes or this decision, we have A, B, C. So if it's A, it means that it's meta-analysis or multiple randomized trials that is informing this recommendation. B means the data derived from a single randomized trial or a large non-randomized trial. And level C is mainly expert opinion or small studies. So when it comes to screening of hypertension-mediated organ damage, what are the recommendations for this patient? Because that will influence whether your patient will require only lifestyle management only or require lifestyle and pharmacological treatments. So the recommendation is, it is recommended to measure serum creatinine, eGFR, and urine ACR in all patients with hypertension. And you see it's class 1, okay? If moderate to severe CKD is diagnosed, it is recommended to repeat measurement of serum creatinine, eGFR, or urine ACR at least annually. So there should be follow-up. Now, renal ultrasound and Doppler examination should be considered in hypertensive patients with CKD to assess kidney structure and determine causes of CKD and to exclude renal parenchymal, and renovascular hypertension. So these are the things that should guide our evaluation. 12-lead ECG is recommended for all patients with hypertension. So you should not say this patient blood pressure is, this patient has 180, this patient has 150. So the one with 180/100 needs ECG, but the one with 144/98 does not require ECG. So far as you've established a diagnosis of hypertension, every patient requires a 12-lead ECG. And the echocardiography is recommended in patients with hypertension and ECG abnormalities, or your history and evaluation suggests there's cardiac disease. And echo may be considered in patients with elevated blood pressures. So like I was saying, if the blood pressure is markedly elevated, you see the level of recommendation is 2B. So it's not because the BP is too high. The fact that the patient is hypertensive, you have to consider that. Then we mentioned about the coronary artery calcium scoring and the use of pulse wave velocity to assess for peripheral arterial disease and other things. But you should know that those ones are 2B. And in our setting, I'm happy it's 2B because these are not things we do routinely. Even for patients that even have evidence of them, they hardly get the opportunity to have them. So it means that we can still give our patients the best based on the current recommendations, but these things are not class 1. Now, what are some of the investigations to look out for if you think the patient has secondary hypertension? Dr. Jibril has already mentioned it, so I'll just briefly mention 1 or 2. Primary aldosterone is common, and so let's look out for it. Don't expect to have a typical hypokalemia, potassium of 2.5 before you think of it. Most of them will have low normal potassium. 3.5, 3.6. Very few will actually have a true hypokalemia. Or you have a patient who you give low dose diuretics and they develop significant hyponatremia or hypokalemia in the absence of alternative explanation. Think of hypokalemic hypertension. And it's not only primary aldosterone, there are other causes of hypokalemic hypertension. Cushing's can do that. So think of it. Because if you don't think of the secondary cause, you will not evaluate the patient and you will struggle with the management of the patients. Okay? Now, in terms of management, you can have what? Non-pharmacological. We are always keen as clinicians to focus on pharmacological. Okay? But you can have non-pharmacological management, all right? And you can have pharmacological management. So every patient requires non-pharmacological, all right? Is the foundation, but not every patient requires what? Pharmacological management, okay? So you have to look at that and we'll get to know who compulsorily needs pharmacological management and who does not. Now, if yes, what pharmacological treatments are available and what will be your preference? You need to look at that. Now, with the non-pharmacological, Dr. Jibri has mentioned, but this is to emphasize that the things he was saying was not just because he's saying it, but there's data and it's being recommended. So with restriction of sodium to approximately 2 grams per day, it's recommended where possible in adults with elevated blood pressure and hypertension, okay? And it's a class what? 1. You know, in Ghana, salt is, we don't even measure it. Every food should taste. If there's no taste, we can't eat, you know, so please. It's difficult in our environment because in terms of preparing the meals, we don't weigh, we don't measure, we just cook and we taste. And so far as it's tasting good, we are good. And this is where it's important to consider the importance of what? The multidisciplinary, the dietitian, the nutritionist to help and advise. What is 2 grams? What exactly translates into 2 grams for the patient to understand? And that is why we need that multidisciplinary management. Now, exercise. Okay, moderate intensity aerobic exercise. Okay, you are looking at 150 minutes a week. But if it's vigorous, you are looking at 75 minutes, okay, in a week. Okay, and the exercise you'll get to know, you can have the dynamic and isometric resistance exercises. And they are all what's class 1. And also weight reduction, of course, we all know he mentioned 1 kilo equals 1 millimeters of mercury. So weight loss is important. We should not forget that and not focus on just prescribing the medications. Now, in terms of diet, he mentioned the DASH or the Mediterranean is class 1. But the problem is, how do we translate this DASH in an environment where, for me, KK and fish is the goal? Do you understand? What is DASH? How can that DASH be translated into our environment? And this is where collaboration and working with the dietitian in your unit is very important. Even if you don't have a dietitian in your unit, you can have a dietitian you can refer patients to or discuss with to help. It's very important. And the alcohol. So when it comes to alcohol, the data on alcohol is you can get those who are for, you can get those who are against. And recently we know a no for alcohol, 0. But if you look at the recommendations, preferably it is recommended to avoid, okay, for the best health outcomes. However, if you belong to the group where you can't avoid, you see where the recommendation is. They are looking at 100 grams per week. The question is, do people even look at the grams on the alcohol they are taking? They are just taking, give me the bottle and let me go. We don't even know the grams we are taking. So we need some practicality in how to translate these recommendations. But it requires us being conscious about it. All right. Then we're also looking at, it is recommended to restrict free sugar consumption, in particular sugar sweetened beverages, to a maximum of 10% of the energy intake. All these are more of theoretical. That is where you need a dietitian. We're emphasizing the role of the dietitian. Over the years, I think we've neglected the allied health and we've placed them on the side, but they are a major part of this fight if we are to win it. And I want to reinforce that the allied health is very important when it comes to management of cardiovascular diseases. Now you look at the exercise, And this is to just let you understand that you can have dynamic resistant exercise. So the squatting, all right? You don't need to go out to do this. So if you're afraid a car will knock you down, you can do this in your room. Okay? Isometric exercise. You know, you can get the handheld one and just do those exercises. These are things that we can easily do or tell our patients to do. Don't tell your patient to sign to a gym. Will you even attend the gym yourself? How many of us attend gyms? Tell the patient, if you, in your compound, walk around briskly till you sweat. Okay? You can't tell my 70-year-old mother to go to the gym. As much activity is better than no activity. So encourage the mobility, the exercise as much as possible. Let's be practical in our plans. Now, it was mentioned earlier on, the replacement of potassium for sodium. It cannot be overemphasized. There's data supports in it. All right. And for patients who are who have CKD or taking potassium-sparing medications, such as ACE inhibitors, you have ARBs, spironolactone, you need to keep monitoring the potassium levels, not to take the patient into hyperkalemic states. Now, who requires pharmacological management? Now, with the 2024, now if you look at the 2024 guidelines, so far as we've established a diagnosis of hypertension, which is defined as BP greater than or equal to 140/90, either confirming with ambulatory BP, home BP monitoring, or repeated office monitoring, that patient requires pharmacological treatment. So now we are not at the place anymore where BP greater than 140/90, we say, okay, this is grade 1, and there's no target organ. So let's do lifestyle for 3 months before, if patient is still not at target, we introduce medications. Now with the 2024 update, so far as a diagnosis has been established with a blood pressure of greater than or equal to 140/90, you require medication. The rule for the monitoring and lifestyle for 3 months comes in those who have what? Elevated blood pressure, which is defined as those who have blood pressure of 120/139, okay, that group, and those above 70/89. So that group are the ones that you want to find out, do they have evidence of established cardiovascular disease? Do they have CKDs, moderate to severe disease? Do they have already existing hypertension-mediated organ damage, or do they have problems already? You understand? And that will define what you do and what is their calculated risk. So if the person already, so that those with blood pressures of greater than or equal to 130/80, all right, and have hypertension, established atherosclerotic cardiovascular disease, have chronic kidney disease, moderate to severe, even though their blood pressure is not above 140/90, such patients, your threshold for starting medication in terms of treatment, pharmacological treatment, is high. You understand? And also your risk. What is their cardiovascular risk? The problem with the ESC guidelines is local context. No, if you look at the ESC guidelines, they use the SCORE risk calculator, which is a purely European-based calculator. All right? They have the SCORE 2, the SCORE OP for the elderly population, and the SCORE DM for those who have diabetes. Now, I want to encourage, and I hope we have people who are willing to help the Ghanaian Society of Cardiology or Society of Family Physicians of Ghana, or clinicians in general. We need to be able to develop a tool that evaluates our cardiovascular risk in our population, because we can't translate these tools directly into our population, because these risk tools are based on population, and so they cannot reflect exact the same risk as it is stated there. Yes, greater than 10% is high risk, but we're using that tool, giving me a value of greater than 10% in the Ghanaian also mean high risk, or with a 5% rather be what we should be using. So I think we should look at developing risk stratification tools fit for the Ghanaian context. So if you look at the flow charts, as you can see, so when you establish a diagnosis of hypertension as of the greater than or equal to 140/90 for the office, all right? But if you are confirming with ambulatory BP, of course, Dr. GB mentioned that in confirming diagnosis of hypertension with ambulatory BP, if you are using the day blood pressure, you are using a cutoff of 135/80. Night is 120/70. The entire 24 hours is what? 130/80. They are using home BP monitoring, they are using a cutoff of 135/85. So you've established a diagnosis, the person needs treatment, not just lifestyle, but needs medication in addition. Those who require lifestyle are those who have elevated blood pressures. However, if they have evidence of blood pressure of greater than or equal to 130/80 with target organ, established CVD, moderate to severe CKD, those patients, even though they don't meet the criteria of 140/90 in the office, you have a low threshold to initiate antihypertensive in addition to the lifestyle modification. Or if they have an established atherosclerotic cardiovascular disease risk that puts them in the high risk group or very high risk group, you need to consider in addition to lifestyle, the medication. So it's important. The only problem is these risk stratification tools are not based on our populations. So we need to look at that. Now, so if establish a diagnosis, the person requires treatment. What medications do we start? What will be our target blood pressure? Because we need to know where we are and where we are going. Now, when it comes to the medications, there's enough evidence to say that now we shouldn't do monotherapy. So the use of monotherapy is not recommended. There are people that will consider monotherapy. All right, those are elderly people, 85 years and over. When they are frail, they are frail, or people who have had postural or orthostatic hypotension. You should be cautious in doing combination therapy. Otherwise, any patient with an established diagnosis of hypertension, now the teaching or the evidence supports what? Combination therapy, all right? Not saying monotherapy. And what options do we have when it comes to when you're starting to do dual therapy, combination? So you have the ACE or ARB, calcium channel blocker, or diuretics, a combination of any of them, all right? So ACE, ARB, CCB, ACE, ARB, diuretics, CCB, diuretics. The preference can be informed by other things that exist in terms of, for example, if your patient is diabetic and has proteinuria, you'll be tilted to ensure that your combination therapy includes an ACE inhibitor or an ARB. If your patient has a CKD, of course, you'll tilt towards ACE inhibitor or ARB in your combination, okay? Now you notice that we do not mention beta blockers as medication that we use to initiate the management of hypertension. The reason is that though beta blockers are hypertensives and used to treat blood pressure, their role is in some cases. For example, you use the beta blockers when there is another indication for the use of beta blockade. So you have a patient you are treating with for hypertension, and the patient has what? Hyperthyroidism. Okay, the patient has a need for beta blockade. All right, the patient already has heart failure with reduced ejection fraction. So in addition to treating the blood pressure, you know from several trials like the MERIT HF, they will benefit from what? Beta blockade. So you make sure beta blocker is part of your medications. So you don't routinely use beta blocker as your first line or as part of the combination therapy in managing someone with hypertension. You are treating a young person and they tend to have significant palpitations as part of their symptoms and presentations. You may want to consider a beta blocker. So there should be a need for the use of a beta blocker. Otherwise, beta blocker as a combination therapy as first line is not recommended. Okay, so you start the patient on the combination therapy and you follow the patient up. You monitor the patient. So you have 1 month to 3 months. Preferably, you always want to optimize your treatment to 3 months and ensure patient is adherent to treatment. Patient comes for review, BP is still not at target. What is our target blood pressure? Now, the target blood pressure is recommended irrespective of whether you have CKD, target organ damage or not. We are looking at less than 130/80. So 120 to less than 130/80. That is what you're looking at. So your patient is not at target. The patient is adherent It's not a patient who takes the drug today and takes the following week. You need to establish that this patient has been adherent and has been compliant. Then you have to go to the next step, which is the triple combination. In our environment, the combination therapies are available, but they are expensive. Most of these combination therapy are not on the NHIs. So most of us will be so forced to do individual medications than the combination therapy. But as much as possible, if patients can do combination therapy, that is what we recommend, because there's evidence that it improves adherence and also improves what? Achieving target blood pressure and reduces cardiovascular disease. So that is what we encourage. So the patient has been on triple therapy, he's adherent to therapy, he's doing the lifestyle in addition, comes and still BP not at target. Then one of the medications is a diuretic. So it's on 3 medications, maximum tolerable dose, doing everything right, and still not achieving target. And this is a patient that you should start thinking of what? Resistant hypertension. At this point, you ask yourself, did I miss a secondary hypertension in this patient? Such patients may have secondary hypertension that had been missed. What labs did I do at baseline? What have I not done? You want to look into that and evaluate. And if you identify resistant hypertension, then you have to give the definitive treatment for that resistant hypertension. But in the absence of that, if you don't identify any secondary cause, then your next option to treat is to add what? A mineralocorticoid receptor antagonist, preferably spironolactone. And if the person is not tolerating spironolactone, or because of the side effect of spironolactone, which is mainly the gynecomastia, erectile dysfunction, then you can opt for the use of what? Eplerenone. And so it's important to know how to approach the patient. Now we need to know some of the secondary causes. Okay, primary aldosterone, we've mentioned it. So what are the treatment options? So if there is no obvious mass to go and remove in the adrenals, it's mainly medical management with the use of the MRI. Okay, but if it's unilateral and can do adrenalectomy, that is also its teamwork. So here you see that the surgeon comes in the management of hypertension. So it's important to know that the management of hypertension is not an individual adventure, but it's teamwork. Now, someone with endovascular hypertension, okay, you've established that the patient has fibromuscular dysplasia or has atherosclerotic mediated renovascular disease. You will need the vascular surgeons to come in to help you. All right, so it's not an individual endeavor, it is team dynamics. Now, obstructive sleep apnea, which we think this patient may have. All right, so you want to involve the respiratory physicians. You may then to forward CPAP, which loss is important. You may even need surgery or some devices. So you may want to involve the maxillofacial surgeon or the dent. So it's important to understand the team dynamics in the management of hypertension. Now, what are the recommendations when it comes to initiating the medications? In adults with elevated BP or low medium CVD risk, all right, BP lowering and lifestyle measures is recommended. So like I said, the person has elevated blood pressure, but the calculated or estimated atherosclerotic cardiovascular disease is so high. So such person, you can just do the lifestyle modification for 3 months and evaluate. And if after 3 months, they are still having blood pressures of greater than or equal to 130/80, you consider adding the medications. In adults with elevated blood pressure and sufficiently high CVD risk, as I mentioned, after 3 months, you need to initiate medications, all right? And it is recommended that hypertensive patient with confirmed BP greater than or equal to 140, irrespective of CVD risk, lifestyle measures, and pharmacological treatment. So you see, you make a diagnosis of hypertension in a young man, and it tells you that I don't want the medications. I want to do lifestyle first. We used to allow that. When blood pressure was maybe 150, 100, we will say it's probably grade 1. So we say go and do lifestyle and come back in 3 months. But now, so far as you've established the diagnosis, they need to start medication unless they request. Remember, the patient has autonomy that I want to do 3 months first. Then, but from now on, we should know that starting medications is important if you establish the diagnosis. It is recommended to maintain your blood pressure drugs treatment lifelong, even beyond the age of 85 years, if they can tolerate it. In the previous guidelines, there were cautions when they are above age 65, above age 75, and all that. But now, unless it's been moved up to 85 years, or they have postural orthostatic hypertension, much as possible, you want to keep them on the medications. Because of the benefit in reducing cardiovascular disease outcome is uncertain in these settings, and nothing that close monitoring of treatment tolerance, but BP lowering treatment should only be considered from greater than or equal to 140/90 among patients. So someone who is greater than or equal to 85 years and he has elevated blood pressure that is greater than, you don't want to start. But then you want to start if it's greater than or equal to 140/90, or they have orthostatic hypotension, they are frail, you have to be careful. All right. Now, in terms of the medications, we said ACE inhibitors, ARBs, the calcium channel blockers, diuretics are recommended, class 1. All right. It is recommended to add beta blockers combined with any other major BP lowering class when there are other compelling indications, like we said, that's class 1. And it is recommended to take medications at the most convenient time of the day for the patient to establish a habitual pattern. You know, there has been discussions on, okay, you have to take it in the morning, take it in the evening. We are pushing it on the patient. You need to let the patient be able to agree on what time is preferred. The most important thing is patient is compliant and sticks to the same time. Now, given trial evidence for more effective BP control versus monotherapy, combination therapy is recommended. So preferable combinations are RAS blocker, either ACE or ARB, with the dihydropyridine calcium channel blocker or diuretic. And I think we have quite a number of these combinations in the country already. So you can determine your preference list and then choose accordingly. The exceptions to consider, as we said, if the person is elderly, 85 and above, postural hypertension, you want to consider monotherapy first for your treatment. In patients receiving combination BP lowering treatment, fixed dose single pill combination is recommended. This we know is clear and evidence is supporting that. And the next one talks about the single pill combinations. Okay, if BP is not controlled with 3-drug combination, adding spironolactone should be considered, like we mentioned, but after establishing that the patient is adherent and there's no missed secondary hypertensive cause. Okay, so the next one talks about the same thing, but we'll talk about the other points later. So what is the target blood pressure? We said everybody should be at what? Less than 130/80. So 120 to less than 130/80. Okay, that's what we are hoping for every patient to achieve. However, you may want to get someone to 125, 128, but the person gets to 128 and is complaining of dizziness. You won't say because the guideline says we should get you to that target compulsorily, we keep the patient there. That's why there's the ALARA principle. Okay, you need to treat to target as low as reasonably achievable. Okay, and you don't want to treat patients and now the patient will have orthostatic or postural hypertension, fall and hit the head and get a subdural hematoma and intracranial cerebral hemorrhage. What have they achieved? So we need to be cautious with that. And the others talks about what we've already discussed. Now we want to look at specifically in CKD, because CKD are a peculiar group, and in the management of this presentation, we have to look at CKD specifically. So with respect to CKD, in patients with diabetes, who are diabetic or non-diabetic, okay, who have moderate to severe CKD, and they have blood pressure of greater than or equal to 130/80, lifestyle optimization and BP lowering medication are recommended to reduce CVD risk, provided the treatment is well tolerated. You understand? So it's very important for us to note that. And in adults with moderate to severe CKD who are receiving BP lowering drugs and who eGFR are greater than 30, it is recommended to target the blood pressure to systolic to 120 to 129. Okay, it's important. And if hypertensive patients with CKD have eGFR of greater than 20, you want to add an SGLT2 to their medications, if they can afford. All right, because you know, apart from the cardiovascular benefit of the SGLT2 also has some blood pressure lowering benefits. So it's a class 1 recommendations. And when it comes to the choice of antihypertensives in CKD, your preference is ACE inhibitor or ARB. Now, what about those with cardiac disease? Okay, When it comes to those with cardiac disease, myocardial infarction, heart failure with reduced ejection fraction, we know that our preference is what? RAS blockers and beta blockers. If those with heart failure preserved ejection fraction, in terms of the benefit when it comes to beta blockade, we don't have strong evidence for that. However, because they tend to have left ventricular hypertrophy, there's benefit for the use of what? ACE inhibitors and ARBs. Okay, but if they have HFpEF, the benefits for use when it comes to beta, the class 1 recommendation now is mainly SGLT2 antagonists when it comes to management of HFpEF, and also there's phenylalanine, but that one is not primarily for blood pressure. Here the emphasis is on what? Blood pressure. Now, in patients with symptomatic angina, of course, if you have a patient who has angina and has hypertension, and you have to choose in terms of preference of antihypertensive, you want an antihypertensive that can improve angina symptoms. So in that sense, your preference will be what? A calcium channel blocker and a beta blocker. Why? A beta blocker will reduce oxygen demand by decreasing your heart rate. Okay, while the calcium channel blockers can also, if you are using the verapamil, diltiazem, they can also decrease your oxygen demand. At the same time, they also improve coronary perfusion by helping with vessels. So it's important to put your patient in context, all right, when you are managing. Then in patients with symptomatic heart failure, we are looking at HFrEF or mildly reduced ejection fraction. You want to make sure that the medications that have been proven with evidence. So if my patient is hypertensive and you know that RAS is beneficial in HFrEF or heart failure with mildly reduced ejection fraction, you want to make sure they are part of your medications to use and your MRA and your SGLT2. Now, in patients with history of aortic valve stenosis or regurgitation who require BP lowering, RAS blockades are recommended. The RAS blockers are beneficial because when it comes to remodeling, cardiac remodeling, they help interrupt the process and help reduce cardiac remodeling and improve outcome. Now, what about our patients who come with cerebrovascular disease or cognitive impairments? You could see RAS blockade with CCD or diuretic also featuring there. And of course, our target blood pressure is similar to those with CKD. So we should look at that. Now, you have a patient with resistant hypertension. We've established 3 medications, optimal tolerable, maximum tolerable doses, still not at targets. One of them including what? A diuretic. You've excluded non-adherence. So it's not a pseudo-resistant hypertension, it's a true resistant hypertension. Then what do you do? Your options are what? We have spironolactone, which is available. Most it's even on NHIS. I think most patients get on NHIS. And when it gets to this point, I will advocate those in primary health care to consider referring the patient to secondary or even a tertiary healthcare for thorough evaluation, especially for secondary causes of hypertension, so that we can improve management. And beta blockers, of course, here may have a role if there's a compelling indication. But if the patient is still not optimized with spironolactone and beta blockers, if indicated, then what options do you have? You have alpha blockers, you have centrally acting medications like mitadopa, you have hydralazine, you have potassium sparing medications like amiloride, etc. But you should remember that the more medications you give, the more risk of side effects. So you need to factor this in your management when you are managing a patient. And when you get to this point, in environment, we are not there yet, but now there's a class 2B recommendation to look at renal denervation, all right, as a way of treating resistant hypertension and refractory hypertension. Refractory hypertension is currently on 5 medications, including a long-acting diuretic like clothalidone, and they're still not at targets. So these are the kind of patients you want to look at the possibility of renal denervation. I don't know whether we've started or it has been done in country yet, but these are things that come in. Now, so it's catheter-based, mainly for resistant hypertension and refractory hypertension. The evidence supporting it, as you could see, the global simplicity registries, simplicity hypertension 3, several trials that have been done to look at the importance of renal denervation. The main concern is bleeding and the femoral access complications, which now they are trying to see if they can do it with radial access instead of the femoral access. Now you have about 0.25 to 5% risk of renal artery stenosis or dissection that may require stenting. And the benefits appear to be modest, despite the cost and all that, it appears to improve blood pressure, looking at 6 millimeters or 4 millimeters by ambulatory. So the benefit is not that drastic or miraculous as we anticipate it will be. So probably as they refine the technique or the scale, it may come up as a first line. As at night, it's not. You have to use it in conjunction with other medications. And you're looking at the cost effectiveness. It's not been fully established. Yes, it helps reduce blood pressure, but if you do look at the cost benefit evaluation, is it something that is going to change practice? And there are few powered studies assessing their cardiovascular disease event reduction. Reducing blood pressure is not the same as reducing events directly. You need data to prove that yes, you reduce blood pressure, and independently, that intervention also resulted in reduction in cardiovascular disease reduction. Now, these are the recommendations with issues. Currently, it's class 2B. It's not a class 1 or not even a class 2A, class 2A. So if you look at it, they said due to lack of adequately powered outcome trials demonstrating its safety and cardiovascular benefits, renal denervation is not recommended as a first-line BP lowering intervention for hypertension. Okay, so we need to know that. Now, there are new and emerging medications. One of them is aprocitentan. It's an endothelin receptor antagonist. It's been approved by FDA in the US and for resistant or refractory hypertension. We all know endothelin causes vasoconstriction. Peripheral vasoconstriction, blood pressure is cardiac output times peripheral resistance. So if you can reduce peripheral resistance, you can reduce your blood pressure. We also have zilebesiran, which is an innovative small interferon RNA that affects angiotensinogen. So indirectly, it's targeting the RAS from the onset. All right. So it's an injection that you don't have to take every day, every 6 months. So this is something that if trial supports, it's going to help a lot of people and those who can afford, and to improve adherence, and hopefully it translates to BP control and reduction in CVD. There's also lorundrostat, which is an aldosterone synthesis inhibitor. So instead of blocking the aldosterone at the receptor level, you are preventing it from being produced even in the first place. So these are things that are coming up that we should look at. So what's our take-home message? You need to always establish a diagnosis of hypertension, preferably with ABPM or home BP monitoring. All right. You need to exclude secondary hypertension and hypertension-mediated organ damage. You need to risk stratify your patient. Remember, your risk will define whether you even start someone with elevated BP on treatment or not. So we need to risk stratify, and don't miss a hypertensive emergency. We could not go into the management of hypertensive emergency for this session because of the time, but if it comes up for discussion, we can comment on that. Management is multidisciplinary. You are not a lone soldier. Remember, it's teamwork, and it's both lifestyle modification and pharmacological treatment. Don't forget the comorbidities, because you are treating the patient to reduce CVD risk in totality and complications, and not just the hypertension only. The target is 120 to less than 130, and your diastolic 70 to less than 79. The exceptional cases, look at the elderly, those with orthostatic hypotension, frailty, and guide your treatment with them. In those populations, you may consider monotherapy. Always schedule follow-up and monitor medication adherence is very important. Ensure effective monitoring of side effects. Most of the patients will stop taking your medication because of the side effect. The erectile dysfunction will stop, even though most of the times it's unlikely related to your medication. So counseling is very important before you initiate them on medications. Know when to refer to a specialist for further evaluation and management. When to refer when you suspect or you confirm secondary hypertension, resistant or refractory hypertension. Thank you very much. And I want to remind you that thank you. So I want to remind you this Saturday, May measurement month reduction of blood pressure is important. So we are working to advocate, to encourage as many of us to be advocates on the management of hypertension. So we start at UGMC 6 a.m. I know Dr. Nketi have not exercised in a long time, so I will see him there, and I'll see all the members of the Society of Family Physicians of Ghana. Thank you very much.
Thank you very much, Dr. Ampofo. but to be corrected, all the functions exercise a lot, right? Yeah. So we have the Ubuntu Kid Fit Club. So we'll actually invite you to join us. I mean, if we join you, you can't beat us. So, but thank you very much for this presentation. Quite an insightful one. Please kindly put your questions. I know a lot of questions are coming in because in the new guidelines that are coming up, which started with the American Heart Association, where they started wanted. Now the Europeans are trying to get there, catching up there with everything that is coming. It's coming into our guidelines as well. I thought I know the cardiovascular guidelines for the country. So I thought you were, because a lot of people are asking questions that is it really related to our environment. So I know questions will come there. So kindly put your questions and in the chat box or the Q&A section as we bring on our sponsors. So this section is kindly sponsored by Pharma Symbiosis and Sanofi. They've been great collaborators and great sponsors and with most of our programs, and really appreciate them sponsoring this section as well. So Pharma Symbiosis, Sanofi will give you 15. They have great plans, and I'm sure you'll present on one of them that is going to align with probably the presentations that have been given. So Pharma Symbiosis, kindly take over.
Thank you very much. Thank you very much. Thank you, Softpop, for this opportunity to have this engagement with you. So I have titled this A Call to Action for Hypertensive Diabetic Patient Care. So a lot has been said already. Thank you very much to the earlier speakers, Dr. Debro and Dr. Eugene Ampofo, for making my work so simple. So currently in Ghana, according to the Ghana Nephrology Registry, we have about 13.3% of the population having chronic kidney disease, which is over 4 million people. This is quite a huge number. 1 in 3 diabetic patients are at risk of CKD. 1 in 5 hypertensive patients are at risk of chronic kidney disease. So your hypertensive diabetic patients are at risk of chronic kidney disease. So as clinicians, what can we do different? We know most of the risk factors being hypertension, diabetes. So some lifestyle, what can we do different as clinicians? So all throughout the earlier discussions, the focus has been on risk factors, risk factors, risk factors. Usually clinicians put a lot of effort into managing the basic parameters for these chronic conditions. So if the person is hypertensive, they try as much as possible to bring their blood pressure to optimal BP range. If the patient is diabetic, they try as much as possible to bring it to optimal blood glucose range. But then again, are we adequately doing a comprehensive risk assessment to ensure that we are giving agents that will not only bring it to optimum ranges, but also prevent the risk factors as well? So in Ghana, the control rate for hypertension is very low, usually between 1.7 to 12.7%. So what are some of the unmet needs in the management of hypertensive diabetic patients? 1, patient not achieving BP goal. Averagely, only 1 out of 5 people with hypertension achieve blood pressure target. This is due to numerous factors such as cost, such as accessibility, myth, and a whole lot of other factors. Also, there's increasing incidence of kidney impairment. Hypertension is the second leading cause of end-stage renal disease. Therefore, we need to make sure that we are able to detect it early in order to nip this risk in the bud. Although patients with hypertension and diabetes are among the highest risk for hypertension-related organ damage, they have demonstrated the lowest control rate. What can we do differently to address these unmet needs? 1, just as has been said, there's been a lot of guideline recommendation from the earlier presentation. So decisions on management should not be based on BP alone, but also on the consideration of cardiovascular risk assessment. We need to ensure that when patients come into our consulting room, we do a comprehensive risk assessment to make sure that we are giving agents that not only manage or bring the basic indices under the optimal range, but also prevent these risks as well. So up to 71% of newly diagnosed hypertensive subjects present with hypertension-mediated organ damage. So patients with diabetes, chronic kidney disease, hypertension-mediated organ damage, and complications fall in high-risk category. This stratification allows for prioritization of options, as we've seen in the earlier presentation. So the updated guidelines reinforces the need for management decisions to be based on patient risk factors and the right fixed dose combination. ARB fixed dose combination is recommended at initiation for hypertensive diabetic patients. So we need to also do timely routine renal screening as well. We have to do timely renal protection screening as well. So every patient who is hypertensive diabetic, it is the responsibility of the clinician to request a kidney profile for such patients, because those patients are at one of the highest risks of getting kidney impairment. So let's look at a case here. So Anne is a hypertensive diabetic patient, type 2 diabetic for 7 years, hypertensive for 2 years. So these are her vitals. So her office BP is 150/94, LDL 7.5, HbA1c 8.9%, and also her BMI is 31.7 kilogram per meter square. She's on metformin vidagliptin 50,000, amlodipine 5 milligram, atorvastatin 20 milligram. So looking at this particular patient who is hypertensive diabetic presenting with all these, what would be our consideration for a patient like that? One, the degree of BP lowering. Looking at our target, which is 120 to 129 for systolic, and the diastolic 170, this is the diastolic 70 to 79 millimeter mercury. We need to adequately stratify such a patient. So looking at her risk profile, and is hypertensive diabetic, she's obese as well. She has a high CV risk, so we need to screen for microalbuminuria. She presented with comorbid conditions as well. So for such a patient, we need to screen for microalbuminuria. So BP treatment should consist of simultaneous combination of lifestyle intervention and pharmacological therapy. So this has been explained by the earlier speakers as well. So now, let's look at the renal continuum shortly. So with the renal continuum, the major risk factors for chronic kidney disease are hypertension and diabetes. And most of the time, clinicians meet this client or this patient in the consulting room. So usually you are the first point of call. Therefore, when you are giving an agent, we want to encourage you to have at the back of your mind that once you are giving an agent, you should be mindful of the risk factors that these conditions are presenting with, so that you will give an agent that will, one, adequately control the basic indicators and also prevent the risk factors as well. So all hypertensive diabetic patients are at risk of renal disease. All hypertensive diabetic patients are at risk of renal disease. So with this, I present to you irbesartan. So this is the Sanofi solution for hypertension, which is irbesartan. The brand name is Aprovel. It comes in strengths of 150 and 300 milligrams. And this is the IMA2 trial. So with the IMA2 trial, 590 hypertensive diabetic patients who already had microalbuminuria were subjected to the Aprovel 150 and Aprovel 300 milligram respectively. And these patients were followed up for 2 years. So they wanted to determine whether Aprovel will prevent progression to overt nephropathy and how it does that. So at the end of the 2 years, it was realized that the Aprovel 150 prevented progression to overt nephropathy by 39%, whereas the approval 300 prevented progression by 70%, which is very quite significant in our study. So we have combination therapy as well, which is Aprovax with irbesartan and amlodipine. So irbesartan as a combination with amlodipine. So this offers cardio protection for patients like so you are getting irbesartan showing benefits in all stages of renal disease, and amlodipine showing benefits in cardio protection as well. So with the Aproval family, if you need an agent that will give you a rapid BP drop, renal protection, and adequate renal protection, choose Aprovax for your hypertensive diabetic patient. So I must say that Aprovax is essential choice for hypertensive diabetic patient, combining BP lowering efficacy and target organ protection as well. So this is how it comes. Approval 150, 300, then we have the combination with amlodipine 155, 150, 10, 305, and 310. We have co-approval, which is the irbesartan hydrochlorothiazide of 12.5%. So beyond its BP reduction, irbesartan offers proven early-stage kidney protection among ARBs. So if the patient has microalbuminuria detected early, is able to totally reverse it. So these are all the ARBs that are known to us in Ghana. So let's look at the pharmacokinetic parameters for irbesartan. So irbesartan is the ARB with the highest bioavailability of 70%, and it is not affected by the concomitant intake of food. So whether your patient has eaten or not, it doesn't affect its bioavailability. It has a half-life of about 15 hours, so you have 30 hours coverage for your patient. I must say that all ARBs have pleiotropic effects, renal protection, in cardio protection, in MI heart failure. But each ARB is unique in how it works, in the sense that each ARB has extensive studies in particular areas. Once again, some in cardio protection, myocardial infarction, heart failure, and renal protection. For irbesartan is a renal antihypertensive. So if you have a hypertensive diabetic patient who is at high risk of renal impairment, irbesartan is a drug of choice for your patient. So with this, I bring my presentation to an end. Thank you very much.
So thank you very much, Pharma Symbiosis Sanofi, for this presentation. So the talk of Aproval, but probably just when you were talking, somebody put in something. So I'll start with you. That what is the cost? Because our cardiologist is saying that we should do combination. And I have a lot of questions here so I'll be coming to our cardiologist, then I'll come to you. But let me start with you. Because already single medications people are struggling to buy. And people don't want to take a lot of medication because of the burden. And of course, a lot of our clients think that if you are taking 2 medications, it means that you are nearing the grave. So to tell them that you need to go on double medications, combination medication, I mean, sometimes they are not happy about it. But you are promising us of a very good one, that probably a single dose medication, but what's the cost? That's what their action.
So you have the various strengths, which is 150, 300 milligram, 155, 150, 10, 305, 310. So it's from a range of 290 to 510. Retail price, yes, 290 to 510 retail price. So Aprovax is one of the most affordable innovator ARBs of the market. So we are midway somewhere, but it has special prices for the hospitals. So in the hospitals, you may get it way lower, but this is the retail prices in the community pharmacy.
Okay, so retail price is saying between 290 and 510. It says that if you go through me to him, of course, you are going to get lower prices. So I'll put my line on. Please, you can go through me to get a lower price. But thank you very much. So, Dr. Ampofo, so their action. I mean, most of our clients, for them to start the medication alone is a problem. And if you manage to convince them, they may decide to go on one. But if you tell them that you have to go on 2 medications from the beginning, a lot of them, I mean, will tell you, you let me start lifestyle, and they may not come back to you at all because you are saying you should go on 2 medications. So someone is saying, what is the evidence behind it that you cannot do a single medication, especially when it is able to control? So are there work that is saying that even if a single one can control, 2 is better? And 2, I may follow up. One of them is also asking, I'm already managing my client. I've been able to manage with 1 medication to target. I mean, the targets these days, with all you are saying, a lot of things are changing. A lot of people are doing the below 140, but current guidelines are actually pushing us to the below 130. But yes, I've hit my target with 1. Do I still need to do a combination? If you can take this from me.
And thank you very much for the question, Dr. Nkech. So, like you rightly said, there is evidence supporting the combination therapy. If you look at previous guidelines, the single pill combination was not class 1 in the past years. But over time, the evidence has come up. If you pick a guideline, probably in 2008, 2010, you may not see this. But there's data. We have the strengths, we have value, we have accomplished. There are trials that have been done which have looked at combination therapy against monotherapy, what target blood pressure, against achieving target blood pressure, and cardiovascular disease reduction. Now, most trials are not looking at just reducing blood pressure. Now, if you are going to give any medication that you say you want us to prescribe, it has to affect cardiovascular outcomes. So every trial should have a cardiovascular arm in terms of outcome. If it doesn't affect cardiovascular outcome, you won't receive approval. So we are not just looking at the blood pressure lowering. We are looking at in terms of what is the relative risk reduction in reducing the cardiovascular diseases. If you saw the earlier slide, the first slide, you saw the forest plots. A 10-millimeter drop in blood pressure reduction when it comes to major cardiovascular disease outcome, death, etc. When do you want to reduce the risk as soon as possible? So that is where the data is pointing. And now medicine is not about what you feel like or what you think. It's about what the data is saying. We understand. Now, you've achieved your target with your single medication. Like you said, we don't know what the person means by targets. Is he talking about 140, 90, or is he talking about less than 130, 80? We are not certain. But of course, if you've achieved less than 130, 80 already for the patient, there's really no in terms of benefit in trying to add on additional medication, which may increase the patient's risk. Remember, in as much as we are pushing for single pill combination from onset, we have caveats that we said you look at your patient's care, you look at your patient and look at it. We had exceptions, people greater than or equal to 85, people had orthostatic hypotension or at risk of orthostatic hypotension. So it's not necessarily for everybody. So let's look at it in that context. Thank you.
Thank you very much, Dr. Ampofo. Dr. Jibril. So I think from both presentations, the ambulatory or the home BP recordings are recommended. Of course, the ambulatory, we can count the number of ambulatory BP this thing that we have in the country. But the home measurements, I mean, it's quite common. And someone is asking, how do I do this very well? And how do I, because we're talking about average, is it taking just 2 of them and checking, how do I get the average to be able to convince myself that this client is beyond 135 and beyond the lower margin of the diastolic? Dr. Jibril.
Okay, so as I indicated, if you are using the automatic device, some of the devices are programmed such that they can take the blood pressure multiple times. So if you are using such a device, you really don't need to take multiple times. the machine itself will take the blood pressure 3 times, and then you will take the average of the last 2. Otherwise, you will have to check 1, and then give an interval of 1 minute, check again, another interval of 1 minute and check. Then you take an average of the last 2 blood pressures. Others, that's according to the European Society of Hypertension Guideline 2023. Yes.
Yeah, but they are asking. I mean, you just check, because a lot of the primary physicians, a lot of doctors will ask the client that go home and check morning and evening for 1 week or for 2 weeks. So the person has come with a whole, I mean, a list of numbers, and you look through. You just look through and choose 2 of them that are beyond the upper limit and say, hey, you are not, I mean, you have hypertension, or you are going to find average of all the 20 BPs that have been recorded, which of course in the consortium, unless you have a statistician sitting by you. So how do you find the average of all the 20 recorded BPs that you've done, average BPs that you've done, to say that this client would have hypertension? So the 2 of you, I mean, can give your comments on that, because it's really, I mean, a concern. Okay, Dr. Ampofo, I mean.
It's interesting how you say you need a statistician. The interesting thing is all you need is your phone to put the values together and divide. But I understand your point. So with the home BP monitoring, essentially all you need is a minimum of 3 days for the recommendations in the ESC 2024, a minimum of 3 days, but preferably if you can do the entire 7 days, it's recommended. And you do morning and evening measurements. Like you said, when we say a measurement, it's as he has described, using the average, and you document that. And like you rightly said, is the average of all the recordings. So you do average the systolics for all and the diastolic for all, and that is what we are using for the diagnosis for the home BP monitoring. So if your patient has done a minimum of 3 days, you can use it. But preferably, if they can do the 1 week, you push for that, then use the average.
Thank you very much. I hope, I mean, we all get it, because a lot of times it's just comparable to ambulatory, which is giving you an average. So this was also an average of the recording. So when they come, don't pick and choose and say that because 2 of them is more than 135, the client has hypertension. It's an average, which is comparable to the ambulatory one. That also gives you an average per the recording that it would give to you. So, Dr. Ampofo, a question comes in for you. A lot of people are worried about your 85. So you're mentioning 85, 85, 85. Someone is 85 is too old, and I'm not afraid and all that. The 3 medications. Can you please touch on it again? And also the target for people who have other cardiovascular diseases like diabetes, where you want to go lower. I mean, sometimes people are worried, if I go too low, how low can I go? Because some also guidelines says that you need to be careful not to go too low. So if you can touch on this too.
So thank you very much. So the 85, if you notice, is actually the cutoff for you to consider monotherapy. So if you notice 85 and above, you are allowed to do monotherapy. And if you have even someone who is not 85, but based on an assessment, the patient is at risk of orthostatic hypotension, such a patient, you have to opt for monotherapy. For example, you may have a 75-year-old on tamsulosin and other vasodilators which predispose them to postural hypotension. You want to do monotherapy. So if per your assessment, the person is at high risk of postural or orthostatic hypotension, 85 and above, or he's 60, 70, but he looks frail. Frailty is not necessarily age dependent. There's a way of evaluating for frailty. So if a patient is frail, those are the patients you need to consider a monotherapy. And with respect to the targets, even though we recommend everyone now to have a BP systolic of 120 to less than 130 and diastolic 70 to 79, remember, you are treating a patient and you are following the patient up. So when patients are developing symptoms that you think is because of the rate of lowering of the blood pressure of lowering, you should reconsider it. It should be targeted. It's a recommendation. Remember, recommendations are not binding. They are guidelines and they guide. And you have to look at the clinical context in which you're managing the patient to make the decision. And with respect to comorbidities, yes, we said for patients with diabetes, CKD, preference is ACE inhibitor or ARB has to be within the combination you're looking at, especially with those with proteinuria or albuminuria. If a patient has heart failure with reduced ejection fraction or mildly reduced ejection fraction, you are looking at ensuring that you also have a RAS blocker in there. And so when it comes to combination, it looks like offered, if you don't want to overthink it, RAS blocker should be there. And plus or minus a calcium channel blocker or a diuretic based on the situation. Because, for example, if you have a patient, but you should be cautious because if you have a patient who you think has bilateral renal artery stenosis, you should be cautious in doing an ACE inhibitor. Okay, so there are caveats, but it appears RAS stands and the rest join it because of the benefit it has. Thank you.
Thank you very much, Dr. Ampofo. Dr. Jibril, somebody is saying that your classification almost confused him because he knows of just 140/90. But if you could go through again, and also the target for confirming the diagnosis of hypertension. So the classifications, and especially if you are doing office, if you are doing home, if you are doing ambulatory, what are the targets so that they can pick their clients well?
Okay. So this is the slide we're talking about. Okay, I'm not going to share. Okay. This is the slide. Your question is on. So for the office blood pressure, it is the routine threshold of greater than or equal to 140/90. Okay. When it comes to ambulatory blood pressure, the ambulatory blood pressure can give you three categories of blood pressures. It can give you the daytime mean, which the cutoff is greater than or equal to 135/85. And this corresponds to the 140/90. And in the nighttime or asleep mean, the cutoff is greater than or equal to 120/70. And then the total 24-hour mean, the average is 130, greater than or equal to 130/80. And all this corresponds to, I keep saying that, corresponds to the office blood pressure of 140/90. So any of these categories, you can diagnose a patient based on these values. And then a home, so for a home blood pressure, the HMBP, that one you are looking at an average of 135/85. The one Eugene just cleared our minds on how to get the average values. So those are all the categories.
Thank you very much, Dr. Jibril. Dr. Ampovo, when it comes to hypertensive medication in men, it's a very dangerous and serious path to tread because the men are complaining of erectile dysfunction. But you make the very clear statement in the presentation that evidence have actually shown that a lot of time it's not really the medication, but the condition itself. So somebody is saying that, can you kindly tell us the medications that are notorious for erectile dysfunction so that in their prescription they can naturally convince themselves of not using that one? Then a follow-up question, another question is the empagliflozin. They're saying that it's a magic drug and that's all sorts of things. So somebody is saying that, what's the role of it in left ventricular hypertrophy and high blood pressure? Do we give to all of them who have high blood pressure, it's more than 150/95, and have left ventricular hypertrophy? Or what is the role of these when it comes to in the management of hypertension? Can you take this two for me?
Thank you very much for the question. So it was one question I was anticipating. That's why I mentioned it in the presentation. So most of the times, there is actually data to show that erectile dysfunction can precede coronary artery disease or myocardial infarction by 5 to 10 years. And so we are not saying that the medications cannot cause or cannot be a risk factor for erectile dysfunction. But what we are saying is that before you conclude that is the medication, ask yourself, have I evaluated these patients for other medical reasons why the patient may have the erectile dysfunction before you conclude? Because even if you look at erectile dysfunction in general, majority of the evidence available is psychological, with few being medical. So if you have a patient, for example, who is hypertensive and diabetic, and it's coming with erectile dysfunction, I'll be more concerned as to whether that erectile dysfunction is vasculogenic, and actually a way of telling me that this patient has high atherosclerotic cardiovascular disease and has a higher risk of coronary artery disease, than rather assuming it is just from the medication and stopping it. So it's important for us to evaluate the patient in this context. Does this erectile dysfunction, is it just medication, is it psychological, or is it a marker of atherosclerosis? Okay, now medications, there's different publications on which ones are higher risk or not, but medications that have been known, obviously calcium channel blockers are major culprits that have been known, but you can find data, in fact, attributing all the medications to some form of erectile dysfunction, but calcium channel blockers, of course, are notorious. However, recently there has been some data specifically for benefit for a drug like nebivolol when it comes to erectile issues. So for me, if your patient has concerns of erectile issues with medication, but this is where maybe the beta blocker may have a role. Then you see, beta blockers don't have roles necessarily for BP. But if, of course, erectile dysfunction is a concern, there's someone I rather want to combine a drug like nebivolol with the ACE inhibitor or ARB because of the concern of erectile dysfunction. But make sure that you are not missing a medical cause of that erectile dysfunction.
Can you please list the categories? Which ones are very notorious for erectile dysfunction for the antihypertensives?
So that's something that, based on the data, calcium channel blockers are corporate. Even beta blockers have been corporate. That's what specifically I said in the nebivolol, because that one has data supporting it. So beta blockers in general are corporate. Calcium channel blockers are corporates. Some will even mention diuretics. But with the beta blockers, the one that stands out, that has some data supporting is nebivolol. All right, so that's why specifically, I didn't want to mention a name of a drug, but for that one, there's data supporting it, so I can see it.
Thank you very much. A lot of people are asking, 3 people, combination of questions, but the underlying question here is low BP. So you have a client that you're managing for hypertension, BPs go low below 100, probably diastolic below 70, sometimes below 5. 2 scenarios, 3 where I'm combining them. So 2 scenarios, one where it is around 100 on 65, 60, but with no symptoms. Do you reduce the medication? Do you let the patient stop, or do you do alternate days? And one, it gets there with symptoms, let's say dizziness. Do you stop the medications? Do you reduce? Or do you do alternate? So both scenarios, one with symptoms, one without symptoms. How do you go around it?
So it means the first answer was not said, right? Okay. So you want to establish the association. Is the symptoms or dizziness due to the hypotension? Because it's important. Otherwise, there's another cause of the dizziness and you attribute it to the hypotensive episode the patient has. Now, it's not recommended to get your BP to less than 120 systolics. The recommendation is 120 to less than 130. In fact, if you look at the previous guidelines, it was specifically being stated in it that you don't want to push your blood pressures to less than 120. So if someone is having a blood pressure of 100 over 60 consistently, and is on 3 medications, is doing well. I think it will be helpful to reduce from 3 to 2. 1, you minimize the side effects, you help the patient's pockets, because there's a lot of pocketitis in Ghana. So by so doing, you minimize. So that is how our approach is. BP is low, it's on 3 medications. I'm already below 120. My target is 120 to less than 130. I've exceeded my target. You can cut off back a bit. You minimize the side effects for the patient and also reduce cost. That's what I would say.
Symptoms and without symptoms?
Yeah, with or without symptoms.
Okay, so that is the answer.
If there is symptoms, it's a very critical, like that one, there's no room.
So if there are symptoms, you stop. Do you reduce?
Oh, I don't. So if there are symptoms, you don't stop. Why? Because the person is having, it depends. Is the person having dizziness as you are seeing the patients, or it comes on and off and you think it's due to that? And also in practice, you always have to look at the patient you are managing. Is it the patient that if you say go off medications and monitor and come in 48 hours or come in 1 week, will the patient be able to do that? So that we are careful the information you communicate. You know, you can have a patient who has that blood pressure of, let's say, 100/60. And you can say, okay, because it's low and you are dizzy, stop the medications. But let me see you maybe in a week with BP profile. You understand? If you can have such a patient, I don't think there's anything wrong in stopping the medication if patient is hypotensive. Why? Because you can fall from the dizziness and cause more injury and give a shot. But if, let's say, the patient says, I cannot come for follow-up until about in 2 months, 3 months, and it's on 3 medications, all right, I think you can cut back and allow the person to come for the review and encourage the person to at least do some monitoring at a nearby accredited pharmacy or community health center that can advise. So I think you should look at it on case-by-case basis and the context you have the patient.
Thank you very much. I think that we've hit our 5:30. Your last word. So I'll start from Dr. Jibril. Your last words and recommendation.
Okay, so for me, my last word will be prevention, prevention, prevention. As I indicated, the factors that play out to leading to hypertension are basically the 3 factors: environmental factors, genetic factors, and then aging. We cannot alter our age. In fact, we want to grow old and old, right? Yes, and our genes equally. So healthy lifestyles, more physical activity. I mean, our life basically is sedentary. We like a lot of comfort. Sit in car, get to the hospital, sit at the OPD. Those of you who may do ward rounds or stand at the theater, you are better off. Some of us just sit at the OPD for the whole day. So for those of us who sit at the OPD for the whole day, I encourage us to do 5 minutes of just a walk around every hour. That's very strict. It's been said that that can reduce your chance of having blood pressure, hypertension by 6%. That's a lot. I would encourage physical activity, and that is very, very fundamental. Yes.
Thank you very much, Dr. Jibril.
Prevention.
Thank you very much, Dr. Jibril. He's talking about prevention, prevention, prevention. And he says that if you can work on your lifestyle, eat well, exercise, even at the consulting room, if you're going to sit for a long time and you're going to have some breakout sections every hour, you could decrease your risk by 6%. And he says that that is very significant. Dr. Ampofo, your last words.
Thank you very much. My last words will be, management of hypertension is multidisciplinary. Let's not think we can manage hypertension in a corner somewhere. It takes more than that. So I think the advocacy should continue, the teamwork should continue, and we should not forget the role of the allied health. They are very important to win this fight. And on that note, I want to see everyone at UGMC, 6 a.m., as I said, on the 10th. Thank you very much.
Thank you very much, Dr. Ampofu. Dr. Ampofu is inviting all of us to UGMC. He says that if you know how to walk, or if you are fitter than him, kindly join him at UGMC as we demonstrate to the whole world that it is part of the prevention. Sanofi Pharmasymbiosis, your last words.
Thank you very much. My last words would be, most of the time, patients come with these chronic conditions, hypertension, diabetes. Once again, aside managing the basic indicators, let's move a step further to do a comprehensive risk assessment so that when we are giving an agent, we'll give an agent that will manage the basic indicators as well as prevent the risk. My last words, my last sentence would be, is either we add to the statistics or we reduce the statistics. Thank you.
Thank you very much, Sanofi. I said last words he gave to, so I'll charge him double. So I want to thank all my online audience. We have over 500 throughout. My in-person participants as well. We really appreciate you. They killed Dr. Ampofo's question. It means that they've been managing their clients well. Our presenters, we really appreciated for this knowledge. A very great presentation that I believe that is going to change the course of management of hypertension in our country, especially at the primary care level. Before we go, a few announcements. As I said, we are having our World Family Doctor Man, where we're having a lot of CPDs. Our next CPD is on the 13th, where we are looking at diabetes, we are looking at CKD. Then we have one on the 15th as well, where we are looking at DM. Then we have one on 22nd. We'll be circulating all this, so be on the lookout. On the 19th of May, which is the World Family Doctor Day, we're going to have lunch of the World Family Doctor Day at all our OPDs and also throughout most of the media stations. It's going to be on mental health, so look out. Let's do this publicity together and let's get this information across. From the 21st, we are driving all the way and we are flying all the way to Tamale, and AGSM starts on 22nd to the 25th. I'm inviting all family physicians. The military manual says it's compulsory for every family physician to be there. See you there. You can count yourself out. On this note, I want to say good evening and thank you all for joining us. Same time, 3 o'clock on the 13th of May. Join us as we take our next CPD. God bless you and have a nice evening.